James. Okay, you guys can hear me enough? Yep, okay. Essentially, I'm obviously a clinician, not an academic, so basically be talking about a little bit of the basis of mechanics and joint positioning in biomechanics, or should say more mechanics rather than biomechanics. It's more clinical mechanics of the foot and the leg, and sort of give out some ideas and a way that I look at treating patients with orthotics as we go along. So a little bit of the anatomy briefly, in the sense of what we deal with mostly is the ankle, the foot, 26 bones. We've got the foot, the ankle to worry about. You've got the tibia, fibula, the knee, the hip. All those structures work together, as you know. We look at the structural aspect as well as the muscular aspect, but most of our emphasis is on the structural aspect. And then we dabble in the muscular aspect, and we hope that you guys can fix the rest of it, because that's what you're experts at. So essentially, I'll just quickly go through that. What's important about this is the angle of your axes and your position of the joints when you're talking about orthotics, because most people tend to look at pronation and, okay, we're pronated, let's lift the arch up and we're fixed. That's not exactly how it works. Pronation is a normal motion, so technically we don't treat pronation. What we're treating is where the structure lies and what the end effect is from heel strike to toe off, as far as the structural position is concerned. And whether the arch is up or down, sometimes that's a positional need rather than whether it's wrong or right. Okay, there's plenty of people out there with flat feet that function quite well, plenty of people out there with supinated feet that function quite well. So what we're supposed to be looking for is the differences and why certain people don't function as well. And then that's when we look at trying to correct it with orthoses. So the ankle itself is obviously a mortise joint, we all know that, but it does have some influences on the fact that it doesn't just go straight up and down. We have a sort of a rotational effect as we dorsiflex and plantar flex. It's not just a straight movement, which is a major component of pronation and supination as well. So that if we can't plantar flex and we can't supinate, then that will affect your gait without any risk, because it'll affect the subtalar joint, etc. So years ago, Inman described the hypothetical cone, which I always thought was a nice little diagram to show the range and how the movement works. So at one end, the joint range is narrower than the other, and that's why the foot structure moves in a certain direction, which is reasonably descriptive in that sense. The closed kinetic chain motion of dorsiflexion with abduction appears to be a forward motion. So essentially, when you hit the ground, there's always an argument, is the leg basically foot dorsiflexing against the leg, or is the leg moving forward on the foot? It's probably a combination of both. To resupinate, you actually have to have the pelvic motion and the body moving to kick off that resupinatory. So it's not a straight plantar flexion and heel strike when you're hitting and when you're taking off. You have to look at the upper body, and that's why there are some influences up the top and down the bottom. And the pelvis influences the foot, and the foot influences the pelvis. Which does more, or what comes first? I don't think anybody knows, and I really don't care. They both have to work together, and that's really what the emphasis should be, is making sure, you know, everybody talks about pelvic stability now, etc., and all that has to work with the foot and the orthotics. But that's the general motion. Basically, it comes down, you've got the rotation in, and as you go forward, it rotates out. But that kick-off is usually because of the body motion rather than muscular motion. Subtalar joint is the one that's probably bandied around most in podiatric circles. They tend to concentrate on that as the bane of all people's ails. Unfortunately, it's not. It's one of the aspects of it. So you do have pronatory effect, inversion, eversion going through the subtalar joint, which is part of the effect. A lot of the studies, is showing that they can't really see the growth movement within the subtalar joint when they're trying to examine motion. So the older theories where you invert the foot with a post or evert the foot, the post moves the subtalar joint into inversion, eversion, doesn't really hold water. But there's definitely a inversory effect or an evertory effect, and that's the issue. So it's not a pure simple drops in or drops out. So people that are maximally pronated is not always just the fact that the subtalar joint is in eversion. It could be neutral, the forefoot could be abducted, dorsiflexed, and the foot's on the ground through results of other accommodating structures in the sense of adapting. Does that make sense? So that you can't just focus on one area of the foot. So putting an orthosis on with just a rear foot post is not enough usually. Now the axial position of the joint, I'm not sort of going to go over those because they're in your notes anyway. So the degrees are arbitrary, they've been studied years ago, they've changed. You've got the basis of 2-to-1 range of motion in the subtalar joint seems to be what they look at as ideal. I looked at 30 years feet, a lot of feet have 2-to-1 ratio with inversion versus eversion, but there's a lot of feet out there that have 1-to-1. Sometimes they're odd as well, so that you can't just put every foot in the same box. But on an average, you should be looking at a reasonable range of motion, essentially twice inversion towards eversion to have an average joint. Don't like the word normal because I don't know if any of us are normal, but essentially we're looking at ideal and average ranges and trying to stay within those ranges when we're looking at patients. So the average subtalar joint, we just went through that. So way we look at it is we put the patient prone and we obviously stabilise the rear foot and move the subtalar joint. So in a sense, you shouldn't be getting any motion from the ankle joint, technically, if it's in the mortise the way it should be, but obviously there are people that have some damage to their mortise, they might move a little bit more, but you're trying to sort of maintain. Having big hands helps because you can usually stabilise it and move the heel into eversion and inversion without too much hassles. Average range, they sort of touts 20 degrees to 10 degrees. I still use that as the model, but I've got patients that will have 30 degrees and 10 degrees, patients that will have 18 degrees and 5 degrees, and all this is an approximation. So you're measuring skin, so you can't see the bone. But the point is that if you're examining that pretty much the same all the time, if you note differences between the two, the differences could be significant. So then you really know where some of your fault lies. Now, that doesn't necessarily mean it'll be the symptomatic foot either. So if you have a structural deviation on one side that's worse than the other, that weakness may be causing stress to the other side. So the symptoms can be a little bit skewish as well. So subtalar joint's supposed to be 45 degrees. What really is important about it is whether it's a high axis, low axis, whether it's medial, whether it's lateral, relative to the average, because that's what's going to have the biggest effect on your orthotic. I don't know how many people use orthotics here. Anybody? Yeah, like the soft ones? Yeah, yeah, okay. Okay, well, the thing with the axis is that a lot of these things are based on the average or the good foot. So they say heat it up with a heat gun, shove it in the foot, they'll be fine. In a sense, you roll up a sock and stick it in the arch, it's going to change your proprioception and change your gait, so you'll have some effect. So you'll always have an effect. The thing is being how precise of an effect are you going to have. Is your post going to be, medial posting need to be coming up past the navic and going towards the first ray? Does it need to be shorter? Does the posting need to be at a high angle or a low angle? All those variabilities denote what sort of control you're going to get from your orthoses. And the control then is restricted because you put that in footwear. So if you're looking at it and I'm saying, okay, all the blurb out there on general orthotics is we've got a 4 degree, everything's neutral, 4 degrees varus and an arch, that's fine, that'll help. Well, you've got compression in the material, you've got loss of that angle on the shoe, so the actual effect of the device can be very low, so that you're sometimes really not changing much at all. Although you may, as you have listened to, I don't know how long with neuromuscular lecture there is neuromuscular effect from wearing orthotics as well. So sometimes, as I say, the stimulus can be enough to generate a positive effect, but you may not necessarily be fixing the problem that caused the negative effect in the first place. It's like taking an aspirin. You know, you can get rid of pain, but that doesn't necessarily means that the bullet that's in the back of your head's been removed. So you need to sort of look at cause versus effect and what you're trying to obtain with the orthotic. And that's what I look at. And I mean, all patients have different objectives too. I'm not going to argue with the patient that they're going to have to wear a surgical boot and a orthotic that goes up to their thigh and for the rest of their life if they're not going to wear it, because there's not much point. But they need to know what's being done for them, whether it's a palliative care or whether it is corrective care. So that's fairly explanatory. I mean, basically, high axis, you get more transverse plane motion in the subtalar joint. Low axis, you'll get more frontal plane motion in the subtalar joint. Medial means you'll offset the mid-tarsal joint, so you'll get more lateral splay, lateral the opposite way around. So the axial positions and the physics are important when you're trying to design the orthotic. So if you've got a high axis subtalar joint and you stick a 8 degree rear foot varus on the back of the orthotic, so you post it in inversion, what's going to happen to the foot? Anybody know, or they want me to answer it? Sorry? Maybe eventually, but what's going to be the first thing that's going to happen? What we saw, high axis has more sagittal plane. So if you reef that rear foot into inversion, you end up pronating, but the reason being is that you'll slide right off the orthotic, because that effect now is not going in the direction that the axis needs that correction. So you may still need to correct it that high, but you've got to think about the slide. So then you may need to have something lateral to stop that foot sliding off, to stop the extrapronatory effect that it's got. So obviously the opposite's the same. If you've got a low axis, you're going to have more frontal plane, so posting in that direction is going to be more effectual. So you might only need 3 or 4 degrees there to get the same effect as an 8 or 9 degree post on a different foot type. So they're sort of the little things that you've got to look at with axial changes, because they're important, because orthotics are a mechanical change. So if you don't look at the mechanics, then you're really not going to get the effect that you want. Okay? And ask questions if you want to, because I ramble on and I don't know whether I'm making sense or not half the time. But so anyway, that sort of explains it. How we examine it is, again, we're just looking visually. So if it's a high subtalar joint axis, when you move the axis, you would expect it to be a little bit more cup-shaped, if you want to do simple. So if you look at the cup saucer, so it's going to, the range of motion is going to be more in a cup. Okay, a little bit more abduction, adduction in the forefoot. If the, oh, where do we go there? I can't see a bloody thing without this. All right.